Good afternoon. We're going to spend a few minutes today talking about the role of economics in healthcare. And I guess if you look at the text that I provided by Diane Dewar, this would be probably chapter 2 in that text. But we're going to talk about just kind of in an economic framework. And sometimes on these presentations or sometimes in these classes, I will actually have a PowerPoint slide up on the screen and kind of talk through that slide. And it's I don't know, I'm going to try a little different approach. I've got my notes beside me and we'll kind of go through it. I think this will be maybe a little easier to understand and a little easier to comprehend as if we go about it that way. And on this particular topic, as I said, I think it's chapter 2 in the book. I'm going to kind of break it into some chunks. So there'll probably be 2 or 3 videos to cover economics in healthcare, the role of economics in healthcare, because it is a very important aspect of healthcare. And people will ask, typically they'll ask you, okay, what do you do as an economist? And especially, what do you do as an economist in healthcare? Well, typically an economist, and it doesn't matter whether it's healthcare, whether it's automobile industry, whether it's restaurateurs you're working with, any market economy. What I typically do as an economist, I'm either estimating something, I'm forecasting things into the future, I'm making predictions about changes in a market, developing options, or different scenarios and assigning probabilities to them. And it's no different in healthcare. The only difference in healthcare, especially when you compare it to some other market economies, is healthcare is extremely complex. It's an extremely complex market. It's driven by uncertainty. There are random events occurring. If you just think about healthcare, and I think we talked about it last week when we were talking about Errol's article, it's the uncertainty of an episode of care, and it's the uncertainty also of the response or the randomness of your treatment plan and the outcome of the treatment plan that makes healthcare so complex and so random and so uncertain. And if you're talking about that's that's from a consumer standpoint. If you're looking at a health plan standpoint, as far as trying to estimate total expenditures, again, it's the uncertainty. If you're on the provider side of the house, again, we've talked about the 2 sides of the financial coin. You've got the providers on one side trying to maximize revenues. You've got the payer on the other side trying to minimize expenditures. And if from a provider perspective, when it comes to forecasting and predicting demand, it is extremely unpredictable. What your demand curve would look like, and if you don't know your demand curve, it makes it even trickier to try to estimate that supply curve. So, again, the uncertainty, the unpredictability of it, it just makes an economist's job in the healthcare environment, it's a little more challenging than maybe in some other market economies and environments. And to start kind of going through the notes, it's economics and policy, and the economist provides an analytical framework. Definitely not a problem solver, but they are providing information to the individual decision makers within typically it's either within a health plan or within a hospital system if you're on the provider side, or maybe a provider group. And the information you're providing is usually to chief actuary, it may be to the CEO, to the CFO, to the COO, to somebody that's in charge of network management, especially when it comes to negotiating contracts. And it's also both on the provider side and the payer side, not only the contracts are important, but you're also looking at medical policy and the efficacy of the treatment plans and staying up to date on what the most efficient treatment plans are, and those that are going to generate the most positive results. And then you've always got that like 800-pound gorilla in the room, and that's on the pharmaceutical side, because as you move forward and new drugs are coming on the market, and some of these drugs are extremely costly. And so as a health economist, you're trying to forecast and predict the impact either on the revenue side, if you're working on the provider side, or you're working with the CVS, or you're working with the Walgreens, or even a Costco pharmacy, or you're on the health plan side where you're working with a PBM, a pharmaceutical benefits manager. You're trying to pull all this information together and help individuals make objective decisions that's going to drive, and in most cases, going to drive the profit engine on an entity that you're working for. And if we look at the nature and production of healthcare services, especially from the micro evaluation level, you've got interventions, you've got medical management policies, you're trying to estimate the market for healthcare, trying to estimate the market for health and medical care. Then to kind of back up, Professor Dewar kind of takes, and as she writes her book, she chunks healthcare out, or the umbrella of healthcare out, into health status and medical care. So, and the health economist is deeply involved in, especially trying to help health plans and to some extent provider groups, trying to develop strategies and trying to provide information that helps develop strategies to improve the health status of a consuming population. Because if you can improve the health status, or at least keep it from deteriorating, it's going to go a long way in controlling the cost of healthcare goods and services that population is going to consume. And likewise, when you're looking at medical care, and again, it doesn't matter on which side of the financial coin you're working, if you're trying to estimate what the occurrence or the demand for medical care is going to be, again, it's extremely important. And there you've got the health economist right in knee deep, right in all of that forecasting and predicting process. The determinants of healthcare, and then if you think about it, it includes things like income, wealth, biology, public health infrastructure, lifestyles of the consuming population, what health interventions either the health plan or the provider group is implementing. So the determinant of the production and the demand on the healthcare system is a function of a lot of moving pieces. If you think about just the healthcare production, just from the production side, and go back to your old micro notes where you were talking about the production possibilities curve. I'm sure all of you were thrilled to have that class. But you're looking at the factors of production. You're looking at labor. You're looking at capital stock. You're looking at, natural resources. And when we talk about natural resources as a factor of production, land is the number one natural resource that most people are concerned with. You're looking at the technology of the production process, and you're looking at the entrepreneurial capability that exists within your company. So if I kind of take a step back, and then whoever the CEO is at Meharry, you're looking at those factors of production, and you're trying to figure out what the cost timeline is going to look like. Trying to project, okay, here's my 1-year business plan, here's a 5-year business plan, here's a 10-year business plan, and you're trying to figure out how all of those are going to work as you forecast and predict the future. And if I'm the CEO or the president of Meharry Medical Center, I'm concerned, as most individuals when they are trying to, whether it's in an economy or whether it's in a corporation, we're looking at, what are we going to produce? How are we going to produce it? For whom are we going to allocate those services? And then lastly, how am I going to save a few reserves out there for me to ensure that we continue to move forward in the future and continue to be a very productive provider in a healthcare market space. So, and it's not just Meharry, it's medical groups and other hospitals in the Nashville market. They're all faced with the same issue, and that's where your health economist is going to come in and help them make those decisions. If you look at healthcare, economics outside of the U.S., it seems to be they are more focused on medical interventions and efficient use of resources, of the factors of production. They are concerned maybe more so with the efficient technology that they use to turn inputs, the factors of production, into the outputs, and those are the healthcare goods and services that are going to be utilized by their consuming population. But if you kind of step back and you look at economists inside the U.S., it's they're focused with the market of healthcare. They're looking at the entire market. They're looking at health status, plus they're looking at the medical care, and their focus it may be a little more widely focused on the intention on the entire market of healthcare. Demand for healthcare is a desire to feel well and invest in your human stock or your human capital. Demand is going to include socioeconomic factors, patient demographics, access barriers, role of providers in determining the scope of services provided, and the underlying underlying mitigating factor that makes things so difficult in forecasting demand is not only the uncertainty but the asymmetric information. So you're looking at your covered population and especially the indigent care, those on the lower with the lower socioeconomic factor, those individuals tend to be more transient than maybe a wealthier population that may be more focused on staying where they are for a certain number of years. And you've got, again, patient demographics. If you look at let's say individuals over 60, if you look at that aging population, they're going to require not only more healthcare goods and services, but they're going to require a different distribution of healthcare goods and services than maybe that younger population, especially a younger population, let's say from 20 to about 40. If you're a male 20 to 40, typically you don't need a lot of healthcare services. Then you hit that, 40th, when you hit your 40s and you're into your 50s, then you're going to start picking up the need for healthcare goods and services. If you're looking at a female population, you've got what they consider the, quote, childbearing years, where there could be a lot of goods and services generated, not only during pregnancy and the delivery activities, but, raising a young child. And estimating demand is going to look at age, and it's going to look at sex, and it's going to look at different distributions among ethnic groups, and it again a very complex market. And while there is information out there that helps us generate forecasts of supply and demand, it is definitely not an exact science. It's not nearly an exact science that maybe you would see in a production factory that know at the end of the day that they're producing widgets. They have a financial model that's going to tell them with fairly certain accuracy, out of every 100 widgets they produce, how many defective widgets they're going to have. Unfortunately, it doesn't work that way in healthcare. One of the aspects of not only asymmetric information is, and Arrow mentioned it in his article, and Professor Gore is going to get into it in her book, as she talks about, and I'll call it SID, it's supplier-induced demand, because with asymmetric information, if you walk into your doctor's office, if you don't have a lot of experience in healthcare, you're going to go in and you're going to assume that the provider that you're going to see is going to be all-knowing, kind of like the Wizard of Oz. It's behind the curtain kind of a deal, and going to be all-knowing, and they're going to provide you the excellent, treatment plan, and you're going to walk out of there and feel like $1 million. Well, it doesn't always work that way. And depending on the financial arrangements that provider has with not only their suppliers or maybe a health system or maybe a health plan, there could be some issues when you talk about this SID or supply reduced demand. And that's what happens if you go into a provider's office and, they start giving you authorizations for all of these, specialty visits, and they want you to get some x-rays and they want you to get some lab results. And, you may want to, spend some time talking to both physical and behavioral health type providers. And at some point, you start questioning how much of that is actually required and how much is it, some kind of a supplier induced demand that's driven by some type of a financial arrangement. And as we move on, and again, like I said, I'm going to kind of break this up because it would take too long to go through all of this in one session, but we'll kind of go on a few more minutes and then we'll kind of wrap up session number one. But as we're talking about the economic framework, supply, economics encompasses, production theory, input markets, organizational infrastructure, cost of production, input substitution, nature and role of incentives. Markets allocate resources and establish prices in equilibrium. And then you're also looking at, macro versus micro. You're looking at small versus large. Both of them, micro and macro, both come from ancient Greek, and micro means small and macro means large. And, both the micro and the macroeconomics are going to definitely impact the decisions that are made both on the provider side and on the payer side within any healthcare market. One of the things that you always need to remember when we're talking about, health economics is remember the underpinnings of economics just in general. So economics is a social science, so it follows scientific methods whenever we can. And we're a social science because we study choice. We study the choices that individuals make, choices about scarce resources, opportunity cost, and making choice. But what differentiates economists from psychologists, social workers, political science majors, those types of social sciences, as one, we're focused on opportunity costs. What is the value, or what is the foregone cost of the next best alternative? And you'll see that a lot, whether you're the CEO at Meharry, or you're head of the hospital at Vanderbilt, or you're in charge of a medical group within the Nashville marketplace. You're always looking at opportunity cost because you're having to make decisions regarding competing wants and it goes back to the unlimited wants. So you're having to make decisions on how to use resources. We have unlimited wants and limited resources. Unfortunately, that's just a fact of life. And the CEO of any hospital, whether against Meharry or St. Thomas or Vanderbilt, they're all looking at the same thing. Do I expand my radiology department? But if I expand my radiology department, do I have to contract my lab work? Do I open a new wing for labor and delivery? Or do I use those resources to expand like neurology or expand cardiology? So they're always looking at the opportunity cost and how that's going to impact the overall performance of their particular entity in the healthcare marketplace. And you're also, the secondarily thing is economics, we are concerned with self-interest. We're concerned with maximizing utility, with optimizing some kind of a functional relationship. If I'm working on that provider side of that financial coin, I'm looking at, I want to see how I can maximize my revenue stream. I want to look at how I can minimize the cost of running my practice. I want to look at how I can maximize the profit that I'm going to make for the investment that I have in my medical degree. And if you flip that financial coin over to the health plan, doing the same thing. They're trying to minimize healthcare expenditures because at the end of the day, they want to optimize or maximize revenue that they're getting in premium payments from employer groups, from individual purchases of healthcare benefit plans. So minimizing cost, maximizing their revenue, and at the end of the day, they want to maximize profits. So everybody on whether on the provider or the payer side of that financial coin, you're optimizing some kind of a relationship. And then finally, we're making decisions at the margin. The example that you typically see in a economics text is where you go into McDonald's. So you're going into McDonald's, you want a hamburger, you want something to drink, and you want some French fries. And you add them up a la carte, and they're like $10. But then all of a sudden they say, and you're trying to decide which of the you don't have $10, you only got $8, and you're trying to figure out which of the ones you have to do without. And then all of a sudden they say, hey, but if you order this value meal, we'll sell it to you for like $7.75. And at that point, you make the decision at the margin to go with the value meal. And it's similar concept in healthcare. You're making decisions at the margin on how you're either going to, on the provider side, build out a scope of services to provide to your patient population. And on the health plan side, you're trying to figure out which contracts to negotiate, which employer groups are to bring in. So you're always making decisions at the margin on how you're going to function in a healthcare marketplace. And then lastly, it kind of gets, I guess, to somewhat, when you're talking about production theory, contracts play a huge role in driving the not only the demand, but the supply of goods and services. So what does the provider's contract look like, either with the government entity, with a direct contract with an employer group, or do they have a contract with, Tennessee Blue or United or Aetna within the national marketplace? And then also on the health plan side, they're looking at, okay, what kind of contractual relationship do I have with 15 hospitals, different hospitals in the Nashville area? So contractual relationships play a huge role in the profitability and the sustainability of individuals, whether it's providers or health plans in a given marketplace. And if you go back again to your micro classes, if you remember, Adam Smith makes two, I think, significant, I don't hate to call them revelations, but he makes two significant comments in his article on the Wealth of Nations. One is, he talks about the invisible hand, and they're invisible market forces. And since the United States is considered a market capitalistic economy, it's a free market force for the, free market forces and a free marketplace for the most part that are driving the supply and demand of healthcare goods and services, driving that equilibrium price and the equilibrium quantity. And Adam Smith says, this invisible hand or these market forces will eventually drive supply and demand to that equilibrium spot. So you'll have an equilibrium price and you'll have an equilibrium quantity. And he also makes another comment, in his article, talking about specialization, talking about the specialization of labor. And if you think about it, I think it was my great-grandfather, no, it's my great-great-grandfather was a country doctor in the state of Kentucky in the 1800s. He was a country doctor. He did some surgical procedures. He, did some, preventive care stuff. He was, an OBGYN. He was an orthopod. I mean, he was kind of a jack of all trades because that's the way the medical practice or his medical practice was set up. But you think of what the medical practices and medical care is like today, and it goes back to that Adam Smith comment about specialization of labor. You've got now orthopods, you've got neurologists, you've got, cardiologists, you've got primary care docs, you have pediatricians, you have nurse practitioners and PAs, and hospitals are even specialized. So individuals or entities within the healthcare marketplace are following specialization. They're looking at that production possibilities curve, and they are operating on that production possibilities curve because they want that comparative advantage. They want the comparative advantage that they can differentiate themselves. So just keep in mind that as you start to look at it, healthcare is a lot like other market economies. And we'll kind of get into that as we go through the rest of this chapter and on down in the book. And also she talks about in her book, healthcare economics applies economic theory, models, empirical techniques to decision making. And you're looking at individuals, third-party entities, you're looking at providers, you're looking at government agencies. And again, it goes back to economics as a social science. And when she's talking about economic theory and models and empirical techniques, she's getting back toward the scientific methodology that healthcare tries to follow. Think about, back in the late 2019, early 2020s, maybe even into 2021. And, COVID was rampant and we were having issues with it, and everybody kept saying, follow the science, follow the science. And that's what economists help to try to facilitate, is to help follow the science. I think with that set of notes, I'm going to stop and kind of conclude on part one. I'm going to take a quick break and I'll come back and we'll launch into part two of the presentation. So see everybody in a few minutes.